Hello, everyone, and welcome to our conference session, Understanding Transplant and Is a Bone Marrow Transplant Right for Me? Thank you for joining us. My name is Julie Powers, and I'm the Senior Director of Patient Advocacy at the Aplastic Anemia and MDS International Foundation. I will be moderating the presentation today. As we get started, I want to take a moment and say thank you to all of the patients, family members, caregivers, healthcare professionals, communities, and corporate sponsors who've made today's conference and our upcoming conferences in 2021 possible, including Bristol Myers Squibb, Alexion, Novartis, Apellis, Taiho Oncology, Acceleron, Genentech, Takeda, and the Every Life Foundation. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or a comment, type your question in the Q&A text box in the window on your screen. When you finish typing your question, just hit enter. We will do our best to get all questions. We do ask that you not include private health information about the patient in question because our presenters cannot answer specific questions related to diagnosis or treatment. We will do our very best to get to all questions today, but we may not be able to get to everyone. If that's the case, please feel free to send your question to us via email at help@aamds.org. You can also call our office during the business week at 800-747-2820 and press extension 2, or you can send us a message on Facebook, Instagram, or Twitter. Today's specialist is Dr. Nakamura, who is the professor in the Department of Hematology and the co-director of the Center for Transplantation and Hematologic Malignancies Research Institute at the City of Hope. Since joining the City of Hope in 2002, Dr. Nakamura has been at the forefront of leading-edge research in stem cell transplantation and the development of cancer vaccines. Dr. Nakamura trained in Japan and served a fellowship in hematology and oncology at the National Institutes of Health in Bethesda, Maryland, before arriving at City of Hope's Hematologic Malignancies and Stem Cell Transplantation Institute, which includes the Judy and Bernard Briskin Center for Multiple Myeloma Research, the Tony Stevenson Lymphoma Center, and the Gare Family Center for Leukemia Research. Dr. Nakamura also serves on the AAMDSIF Patient Education Council. Please join me in welcoming Dr. Nakamura to the conference today. Hi, Dr. Nakamura.
Hello, hi, good morning from California. Thank you so much for the very kind introduction. Can you hear me okay?
I can hear you just fine, Doctor. Thank you so much. It's all yours.
Oh, okay, great. So we can move on to the next slide, please. So these are my disclosures today. Additional disclosure would be that I'm speaking from my house today, and you might hear some noise from my kids or dogs. So please excuse if that happens. Thank you. Next, and again, it's a beautiful day, and thank you for joining us in this weekend, precious time. And we'll be discussing today about the stem cell transplantation for bone marrow failure diseases such as aplastic anemia and myelodysplastic syndrome. The topics that I'm planning to cover includes some basic principles, some procedures, general risks and benefits that are associated with stem cell transplantation. And we'll go into some more specifics on aplastic anemia, how the procedures made some advances in recent years, but still remaining some challenges that I like to discuss and share with you. And myelodysplastic syndrome, for this disease, the main topic that I'll be covering is regarding transplant versus non-transplant therapy, particularly in older adults, since this tends to occur in older age. Next slide, please. So allogeneic stem cell transplant is the only potentially curative treatment for many hematologic disorders by eliminating, malignant, so the cancer type hematopoietic clones through conditioning chemoradiotherapy and a very strong immunologic effect called graft versus leukemia effects that the donor's immune system can attack and eliminate bad cells in patients. And then restore hematopoiesis, so good blood cells from donor-derived hematopoietic progenitor cells. However, the procedure is associated with significant risks of morbidities, complications, and even mortality, and also needs to have a immune compatible donor to do the stem cell transplant. Next slide. And so this procedure was really pioneered by many people in early 70s through 80s. One of them, a giant in the field, Dr. Don Thomas, was the recipient of the Nobel Prize for his contribution to developing this procedure and providing cure to many people with devastating diseases. Next slide. Now, the types of blood diseases that can be cured or actually require a stem cell transplantation for long-term survival it includes leukemias, lymphomas, cancer type diagnosis, and the lack of production of blood cells, namely bone marrow failure syndromes, and most importantly and famously aplastic anemia. And that just a slide is showing how the bone marrow or cells look like. Left side in normal appearing bone marrows, but you can see the bone marrow of the aplastic anemia patients are very thin, very few cells remaining. Next slide. Now, if we look at actually the information at the Centers for Medicare and Medicaid Services, so it's a national coverage statements. So the first indicated diseases for transplantation was leukemia, leukemia in remission, or aplastic anemia back in 1978. And since very limited diagnosis, actually, if you realize, have been approved by the CMS for the coverage, including severe combined immune deficiencies, Wiskott-Aldrich syndrome is another sort of congenital disease. Myelodysplastic syndrome has not been officially determined as a disease that would be covered by the CMS. However, the office did issue a statement in 2010 that the patients can be covered for transplants if they are under such studies that are trying to develop evidence that the Medicare beneficiaries can in fact benefit from this procedure. And I'll discuss a little more about this later. Next slide. And stem cell transplantation is not really a surgical procedure, as many of the patients ask at the first consultation. And this is more or less a transfusion of the cells harvested from the donor in the left side. Over 90% of the transplants are done through stem cells harvested from patient's blood as opposed to the bone marrow itself. And after the patient receive some pre-transplant conditioning therapy on the purpose of clearing up all the bad cells and opening some space in the bone marrow for new cells coming in. and sufficiently suppress immune system of the patient so that they cannot reject the cells from the donor coming in, even in the setting of matched donor cells. And the stem cells are infused like a transfusions through the veins. Next slide, please. Now, there are some diseases, however, including aplastic anemia and many of the pediatric diagnoses that bone marrow cells as opposed to blood stem cells are preferred. And bone marrow cells are being harvested using needles. So again, it's not surgical operations per se. There is no cut open kind of process, and pour some of the blood-looking bone marrow cells through the needles, and takes usually about an hour or so. Next slide. And I'm going to just kind of take you through the timeline and the processes just in general without the going into details. And typically, patients receive this conditioning regimen, which often include some form of radiations or chemotherapy. ATG we'll talk briefly about. It's often a part of the regimen, especially for aplastic anemia. And globally, the regimens are grouped into fully myeloablative regimen, very intensive therapy for young adults, malignant diseases, versus reduced intensity regimens, which are commonly offered to older adults or patients with some other medical issues that the high intensity regimen is considered too risky. And the infusion of the cells, we usually call it day 0. And donors can be matched sibling or unrelated. Haploidentical donor, I'll explain a little bit later, cord bloods or mismatched donors. And again, the infusion takes place on day 0 for usually about an hour or two. The infusion will be done. The treatment does not really finish there. It's not a surgical procedure, but it's a process of engrafting blood stem cells and harmonizing, in a sense, the immune system of the two individuals between the donor and recipient. So need a lot of adjustments on medications that can navigate the process, and takes many months for us to feel stably engrafted without graft versus host disease, which is the immune interactions between the donor and host, and less dependent on pharmacologic supports. And then we start to look into so-called survivorship. So due to previous exposures to chemotherapy, transplants, some immune-related complications, that there are certain health maintenance items that we have to pay attention to, which would include re-vaccinations for measles or lupus or tetanus shots, etc. And we'll probably touch upon the COVID-19 immunization during this session. Next slide. And when we talk about the bone marrow failure syndrome, I think this audience is quite familiar with the spectrum of the condition as opposed to a disease per se. And left side the cartoon shows multiple diseases that are overlapping in between, in the kind of spectrum from very pure immune-mediated bone marrow suppression of aplastic anemia to so-called clonal evolution, PNH or MDS, and in rare occasions even can progress into acute leukemias. On the right side, I try to kind of depict this in a little more simplistic way. And often when we see patients with low blood counts, can be due to autoimmune suppression. So the blood cells, bone marrow cells are healthy but reduced in number because the immune system is acting up and attacking against their own bone marrow cells, being aplastic anemia. But pure sort of myelodysplastic syndrome is more about diseased or genetically changed stem cells overgrowing against healthy cells, and patients in between or overlap can have kind of both mechanisms simultaneously ongoing. When aplastic anemia tends to happen in younger age, MDS is a disease for elderly, and approaches transplant results or indications kind of a little different between the two diseases. Next slide. And the purpose for the transplant is again slightly different. The aplastic anemia, mainly we need to eliminate this autoreactive immune system with this conditioning and the new immune system from the donor. We don't have to deal with sort of cancer type cells and just put back healthy stem cells from a donor. In cases of MDS, we need to clear up this diseased MDS type stem cells, which can eventually progress into leukemia if they are left out, and so tends to need a little more intensive chemotherapy or like blood stem cells, for example, which may have a little extra kick into the patient's leukemia cells. Still, both diseases, we need to get the healthy cells back up. Next slide. And I think you may have seen this, that in the natural history of aplastic anemia back in 70s, this was a really universally devastating and lethal disease. And I've often quote the studies that about 90% of the patient will be dead within a year from the diagnosis, when we had only primitive treatments, just whole blood transfusion, for example, even not components, platelet red cell transfusions. The androgen testosterone was one of the first treatments that became available in 70s, but you can see that many people are dying in early age soon after diagnosis. But it's very different nowadays. Next slide. The history will continue a little bit, that the people started to try a bone marrow transplants early on, but what was observed was the patients who rejected the donor's bone marrow cells, they could still restore their own bone marrow cells after the procedure, giving a hint that this could be improvement driven by this chemotherapy or ATG therapy used as part of the transplant. So even when the donor cells did not engraft, some people responded, and in laboratory there are lots of studies started to accumulate that there are some underlying inflammations, autoimmune processes, and developed into immunosuppressive therapy as one of the very effective treatments, along with bone marrow transplant. Next slide, please. And so this talk is mainly about the transplant, but still I think it needs to kind of contrast and discuss in the context of available immunosuppressive therapy. And this is one of the famous studies from the NIH, Dr. Young and others, that if you have a very good, robust response after ATG treatment on the top curve, that the survival rate is really good, over 80, 90% range. Next slide. And more recent advances includes L-thrombopag or Promacta added to standard cyclosporin ATG treatment. And this study was also conducted at the NIH, where the response rate was really good, over 80%. Whereas historically, ATG cyclosporin have been associated with somewhere between 60 to 70% the response rates, and over 95% of the patients are surviving at the follow-up time of 2 years. Next slide. However, there are some late effect issues in the immunosuppressive therapy, and this is one of the examples of a secondary clonal diseases, namely PNH, aplastic anemia, and it's been observed that up to 5-10% of the patients can develop some of these different blood diseases out of the history of a background of aplastic anemia. Next slide. Now, what about the bone marrow transplant? And so the transplant has been really successful again. This study is involving City of Hope, Fred Hutchinson Cancer Center in Seattle, and the Stanford group, and was reported 20 years ago with survival rates around 90% even back then. And this is a study with the sibling donor transplant matched. Next slide. And the national data is similarly good, especially for patients in young age with the matched sibling donors available. Unrelated donor results are trailing a little behind, but it is improving. For example, next slide, please. Okay, actually, so let me step back and just next slide is fine. Thank you. Yes. So unrelated donor transplant was very challenging and difficult in early days of transplant, actually. So in this series, the table shows the survival rates in only around 40 to 60% back in 90s. The next slide, please. So we, under the national consortium group called Bone Marrow Transplant Clinical Trial Network, had series of studies to try to improve upon the outcome of patients who don't have a much sibling donor. And so this is one of the latest that we came up with some newer combination of chemo drugs incorporating fludarabine, cutting down the dose of cyclophosphamide. You don't have to remember all of this. We're not going to test you, but the bottom line is that with the current commonly used regimen, the outcome have been good. Again, 80-90% kind of range we can expect. Next slide, please. A challenge, however, we have to address, and we have to, I have to share with you, is the availability of the matched donor. So when it comes to matched sibling, of course, depends on the size of the family. On average, only about 20% of the individual nowadays have a HLA compatible sibling donor available. the donor registry worldwide has over 30 million people, thanks to many kind and well-minded people, that a large number of donors are registered worldwide, and that they are accessible internationally. But still, because these HLA molecules diversities are relatively preserved within the kind of net own ethnicities and races, and because the donor pool has been predominantly Western Europe and North America, that the Caucasian population have a much better chance of finding a well-matched donor, over 70% nowadays. If you allow the 7 out of 8 match donors, which is a very good and available usable donor, nearly 100% of the white Europeans will find the donor. In contrast, the racial ethnic minorities, especially African American populations, have a very low chance of finding such donors through the registry. Next slide, please. One of the approaches and techniques to overcome the lack of matched donor is to use mismatched donors or haploidentical donors, which means the patients and the recipient patients and donors share only one set of the chromosomes or gene sets. So essentially, it's a half match family member transplant. And that has been very successful by using so-called post-transplant cyclophosphamide, originally developed at a group at Johns Hopkins. And you probably hear about this term quite often. And the results, early stage, but look very, very promising. And we did actually duplicate this study as a network nationwide, as I mentioned, BMT-CTN. We do not have the results from the study, but hope to replicate what was seen in Baltimore in a nationwide project. There are also, good studies published using cord blood, umbilical cord bloods, often from the Eastern Asian countries, Japan, Korea. But in the United States, I think haploidentical donor transplant is becoming more commonly offered. Next slide, please. Additional challenge besides the donor availability is the age issue, that the aplastic anemia is a disease often in pediatrics or young adults. It's not very common in older adults, and either due to it or maybe there is some pathologic differences. Of course, older adults have other health issues as well, that the transplant outcome is not as good as in young adults. Next slide, please. A promising result, however, came from it's a UK, that age may not be necessarily a huge barrier, but the number of the patients is still relatively rare in this rare disease to begin with. That's one of the areas to look into. Next slide, please. And the last item I wanted to also bring up into this session was long-term effects. So let's say both ATG cyclosporin promacta and bone marrow transplant, the success rates are remarkable. I mean, in the past, 90% of patients were dying within the first year, but now if they arrive to the tertiary care centers in time and receive either ATG or bone marrow transplants, over 90% of the patients are surviving, in the first few years. However, it is known that, because possibly of the previous cancer diagnosis, leukemia, transplant, many factors, that the patients who survive the first few years of the transplant still have a higher risk for mortalities, morbidities compared with the general population. And this is a study by Dr. Wang and Dr. Armenian at City of Hope, showing even, for people who survived after transplant 10 years, that the curve indicates that they still have a higher risk for some medical issues, and age adjusted, people have to deal with medical conditions. And this is not really due to transplant itself, actually, not from graft versus host disease or recurrence of their leukemia at that point, but say, heart attack or stroke or many other health, common health issues that have to be, carefully followed. Next slide, please. And there was a specific study. Well, actually, these two national studies did include also leukemia, MDS, lymphoma, but also aplastic anemia. And again, many patients with aplastic anemia succeed in transplant in curing their disease. However, still, there seemingly still be some risk of health issues later time. So just to, next slide, please. Okay, so it's a summary. So just to briefly summarize, I think it's sufficient to say that we have made a significant advance in improving outcome of severe aplastic anemia with the bone marrow transplant being a very effective and curative therapy. Immunosuppressive therapy is also very effective, and really, the immediate outcome is really good. But finding a donor and the late evolution of hematologic disorders after immunosuppressive therapy, or sort of more like a late health maintenance or healthcare issues in transplant survivors. I mean, those, I think, still need some research and attention. One thing I did not really talk a lot today, but maybe covered by other speakers, is that it's very critical to have the early referral to a center which can offer both options, transplant and ATG cyclosporine. It's very, very difficult to help patients when they become really sick already, having active infections and pneumonia. It's not, safe to try transplant in that kind of situations. And as you know, ATG treatment can take 2-3 months for that to have effect on recovering blood cells. So really like to emphasize that the referral needs to happen sooner than later. Next slide, please. Now moving on to MDS for a bit, and again, I know this diagnosis treatment approach have been covered by other speakers today. I'm gonna just start off with saying that this is really a syndrome, suggesting that we really don't know what it is. It's not even a single disease, and people, including us, put a condition that had a similar features, namely low blood counts, dysplastic appearance of the cells, and the tendency to evolve into leukemia into a category of this syndrome, myelodysplastic syndrome. Next slide, please. And I just briefly mentioned that to make the diagnosis of this syndrome, you have to have a few shared clinical features, low blood counts, funny or strange shapes and size of blood cells, and by some genetic testing, chromosome or mutations, to have the evidence that this is a clonal hematopoietic disorder, and that's how this diagnosis is, or concept of this diagnosis evolved. And the enemies or challenges, issues from this diagnosis is low blood counts, which people can die from, and transformation into more aggressive form of blood cancer, acute myeloid leukemia. Next slide, please. And at this date in 2021, the only curative therapy is hematopoietic stem cell transplantations. There are a number of approaches which can improve the natural history, meaning delay the transformation into leukemia, so improve survival by using hypomethylating agents, other new drugs, and also the supportive care has been quite nowadays sophisticated, with transfusions, growth factors, antibiotics, and so forth. Still very important. Next slide, please. And this is not a transplant, but just to kind of give you idea that how the MDS patients do with hypomethylating agents without a transplant, using azacitidine or decitabine. Sorry, there is a typo on the title. And now it's a classic paper, but the groups produced in the US and Europe, both demonstrating the benefit of survival with azacitidine compared to patients who were randomized to receive non-azacitidine type treatments, supportive care in the left side, and chemotherapy or supportive care on the European trial. Next slide, please. The other cytidine, decitabine, however, are not really a curative treatments. After some time, which could be 6 months, could be 1 year or 2 years, essentially almost all the patients start to reprogress with their MDS. And once the MDS start to reprogress, the outcome prognosis is really dismal. Next slide, please. So the transplantation, again, has been considered for this diagnosis, and we knew early on that it's a curative treatment. However, as we talked, patients can die from complications, including infections, graft versus host disease, and still a small fraction, not very many, but of the patients can break through with MDS again, even after going through the transplant. So the transplant is not really a perfect therapy. Historically, though, that the younger patients, with MDS, very not common to happen in younger adults, but typically, transplant is offered early on for those patients. The questions were for older adults. Again, MDS, the median onset or diagnosis is late 60s, early 70s. That the traditionally transplant was not very commonly offered. And that relates to, the statement I shared with you that the Medicare, Medicaid services did not really offer a blanket approval of this procedure to their beneficiaries, and asked us to provide evidence that the transplant actually, in fact, helps. There's a couple of European studies, as shown in this slide, left from the French group and right from a German group, similarly designed, registering patients with MDS at, some of these at diagnosis, at referrals, and follow the outcome depends on the availability of a donor. So those who did not have a donor found, most of them did not proceed with transplant. Those who had a donor, most of them proceeded with a transplant. And in the first year or two, there isn't really a huge a difference, but again, being a curative therapy, transplant offered the survival benefits after a year or two. One of the studies that the United States Transplant Group performed is simply compare the very older or Medicare age group of age 65 above patients versus age 55 to 64. And in transplantation, there wasn't really difference in the outcome on the the figure down below, and so that was one of the evidence to support that age alone should not be really a factor to not offer transplantation for those people. Next slide, please. And we also designed a more definitive study. We enrolled close to 400 patients on this, that the patients who were referred to transplant centers and appeared to be a transplant candidate. We registered them and determined in 3 months whether they have a matched donor or not, and analyzed the outcome according to the donor availability. And this largest study to date, clearly demonstrated the benefit margin of the transplant or having a donor versus not having a donor, with about 20% difference at 3 years. And the next slide, please. And this benefit was, really seen across different sort of subgroups within. I'm sorry, my dog is excited. I'm excited with this study as well. And this was presented at our recent meeting, and hopefully, published in some journal soon, that the whether they responded or not responded to Bidesa Dacogen, whether the age was below 65 or above 65, IPSS scores, the transplant showed the beneficial effects over non-transplant therapeutics. Next slide, please. So I think we are going to summarize this part, that the transplantation is also very highly effective and curative therapy for MDS, and that the age alone should not be used as a criterion for selecting transplant candidates. This study, and we at City of Hope perform transplantations, very commonly, regularly, in their 70s, close to 80s. So I hope that the data in these studies, US and Europe, will encourage patients with a diagnosis of MDS, and also actually doctors who are treating these patients to, at least consider having a discussion about, a transplant or not. Of course, transplant is not necessary for everyone. I mean, really have to carefully evaluate the conditions, situations, health status, everything. But I like this to be considered at least and discussed. And here again, just like aplastic anemia, we'll be encouraging early referrals to incorporate the transplantation as part of the whole, packaged treatment scheme for MDS over time. And that still research involves, requires us to how to get to transplant, how to transplant, and how to support the patients. Again, MDS patients are generally older and needs to have better tools to assess their health status, and very complex genetic landscape of mutations in this disease, hopefully leads to better personalized medicine approaches. So I think this is the last slide. Next, please. Thank you for your attention and again joining this session. This is a picture of our bone marrow transplant reunion. We had to cancel this last year due to the pandemic. This year also probably going to be a virtual reunion, but hopefully soon I can see you as well and hear you. But thank you again for your attention and support.
Thank you so much, Dr. Nakamura, for your wonderful presentation. As you can imagine, we have a number of questions that have come in from people who are watching with us live today, as well as a handful that were submitted in advance. I'm going to start with the first question, which is, would you consider transplant an option for a young adult with moderate aplastic anemia with decreasing cell values that approach severe, but otherwise healthy, no transfusion, and have a 5-5 unrelated match in order to have a cure and avoid immune therapy?
A great question, and maybe I can kind of expand the group of patients, and maybe I missed to actually share. So, with the advance and the improvement in immunosuppressive therapy too, so I think this case is untreated, moderate aplastic anemia, but treated aplastic anemia patients with sort of imperfect response, and we see those patients quite often, after 5 years, 10 years, even 15 years, kind of dealing with the disease on and off, not threatened for life, right? I mean, it's not a life-threatening situation, not even needing transfusions in some patients, but, symptomatic from anemia or issues, with the platelets, procedures, having families, pregnancies, all the aspects come in. So I tend to be very open for offering a transplantation for those who are, very well informed about kind of pros and cons of continued observation versus continued immunosuppressive therapy versus, sort of curative definitive bone marrow transplant. For me, it's a little harder if they are not needing transfusions. But right, I mean, I think if they are symptomatic enough to feel that the quality of life is diminished, and the trajectory of longevity, survival rates over the next 5 years, 10 years appears to be, getting jeopardized. I think transplant can be justified again, with the good results, generally speaking.
Thank you so much, Doctor. Our next question comes from a patient who wants to know about how do you handle transplant for folks who have a large PNH clone? Is there a preconditioning regimen that you might undergo for a PNH patient And are PNH patients good candidates for transplant? So can transplant cure PNH?
Yes, thank you. And I was afraid that this question is gonna come up today. It's a whole another topic I think we can discuss. But let me maybe put into two categories. One, let's start with aplastic anemia / PNH. So bone marrow failure, production failure as a background, but some degree of hemolysis with PNH, or the PNH clone as sort of associated less clinically significant situations. And for those, the transplants are often usually performed according to the way we transplant for aplastic anemia. We have actually incorporated the use of Soliris during the first, few weeks, just to cover and prevent sort of, active hemolysis in the middle of transplant. There have been some kind of small animal studies suggesting a complement inhibition may prevent graft versus host disease. So that have been kind of our common practice, with caution, of course, for the infections and other risk. When the spectrum of PNH plus aplastic anemia is more towards PNH, meaning that the degree of production failure is relatively mild, but the issues are more about hemolysis. Then the discussion is a little bit different, and of course, now Soliris, Ultomiris, the complement inhibition eliminated the need for transplant in many of these type of patients. But again, assuming the case we're talking about is a lot of hemolysis, but also say neutrophils are low, platelets are low, and needing transplant. We sometimes, not always, but sometimes we shift the transplant regimen towards more like a MDS type regimen, not like as intensive as leukemia type regimen. I don't think we need that heavy duty radiation chemo, but often need a little extra chemo drugs to kind of knock down the PNH cells to open space for a better engraftment. But again, there aren't really much data or studies in this unique group. So I'm just saying our practice approaches in general here.
Thank you so much, Doctor. A follow-on question, or maybe a tangential question to that, is in the event that there is a sibling donor, would the pre-transplant testing include a test for the PNH clone?
Not routinely for the siblings. So that's another actually you're getting into a very interesting and topic of research, again would need probably another 1 hour about what to do with the donors hematopoietic system. I mean, at this time, any healthy cells are often of course better than the patient's diseased bone marrow cells. So currently we just do blood counts and the health histories, and if there is nothing suspicious concerning, that's it. But right, if there is some family history of blood disease, or some blood tests showing something funny, we go deeper. And of course, right, if there is a documented blood disease, we would not be using such donor. But nowadays, again, the other speakers might have talked to you. The clonal hematopoiesis, or so-called CHIPS, some degree of genetic changes is very commonly found in healthy people, and how to deal with that kind of situation is still under intensive research now.
Thank you so much, Doctor. Our next question comes from a patient who wants to know if bone marrow cellularity would have any impact on transplant success in benign bone marrow failure diseases?
That's another good question. And, the short answer is no. And let me, phrase it too in the setting of aplastic anemia that the cellularity really doesn't have a prognostic implication, as much as blood counts actually. So it's more important that what's being produced in blood. The outcome of aplastic anemia in general, whether transplant or ATG, the degree of cytopenia matters. The another side of the common question from the patients is that even if the blood counts are good and the bone marrow is still hypocellular, physicians or patients are worried that they still have aplastic anemia. But not really. I would argue that as long as the blood counts are fine, they're fine. The bone marrow is not necessarily very unique. I mean, it can be very patchy, so depends on where we sample. The cellularity can vary as well. So so again, the bone marrow cellularity is not a huge factor that we care about in terms of the treatment response or prognosis per se. It's important for making diagnosis, of course.
Thank you, doctor. Our next question comes from a 72-year-old patient who has a previous allogenic transplant as well as renal cell carcinoma. Would they be excluded from consideration for a transplant for MDS-U? Their adrenal glands were removed in 2012, but they're doing great now.
So I would say short answer is no by just the face value. Yes, I mean, we kind of put all the medical issues in totality as opposed to a single history. I mean, prior allogenic transplant. So if you're asking, the MDS arises out of the donor's bone marrow cells, essentially. There are patients who receive the second allogenic transplant from a different donor in that kind of situation. So it technically can be offered and done, as long as you're very healthy otherwise and pass basic tests for lungs, hearts, and kidneys and overall health condition.
Thank you. Our next question comes from a patient who's 74 with MDS in good health, low risk, 2% blasts with no other choices for ESA agents. Should they continue with red blood cell transfusions every 4 weeks with chelation therapy, or should they consider hypomethylating agent treatment or transfusion? What would you suggest in that situation?
Yeah, for the low risk MDS patients, again, for that age group, I mean, the common sense and the general, recommendation is to, stay on the low risk, low intensity therapies. I mean, I have, had many patients who are living on transfusions. I mean, it's not good and easy, but, it's not, if it's only red cells, it's not necessarily life-threatening immediately. There are a number of promising drugs, including luspatercept, Revlimid, I mean, etc. I mean, there are drugs that can still be tested out beyond erythropoietin. Again, we, as I mentioned, we like to have a transplant discussion as part of it. But I doubt that transplant physicians would recommend to proceed in that kind of a clinical situation.
Thank you, doctor. Our next question comes from a patient regarding mutations. The patient had ASXL1, EZH2, and monosomy 7 prior to bone marrow transplant. Post-transplant, they have ASXL1 from the donor in another part of the DNA chain. What are your thoughts on a possible relapse as a result of this?
So if it's arising from the donor cells, I mean, we kind of touched upon that from the previous, question. At this time, what we know is that there is no major clinical impact of the donor-derived chips in terms of, the success of transplant for MDS. I mean, I would say actually, there is the best study from Europe indicated that patients who received the donor with that type of mutations, doesn't not necessarily ASL1, had a slightly, somewhat a little higher risk for chronic type graft versus host disease and somewhat reduced risk of relapse of their leukemia. I don't want to kind of make this sounds definitive. It's only one study, but so there could be some, kind of both, somewhat beneficial, effects from this. Again, I would kind of leave that to a topic for future research. And to just to reassure that there wouldn't be any sort of major concern by having that donor with that mutation at this time.
Thank you so much, Doctor. Our next question comes regarding the COVID-19 vaccines that are currently available and that are in the pipeline. Can you talk a little bit about the plans for should pre-transplant patients get vaccinated now, and what is your plan for vaccination post-transplant in terms of timeline?
Yeah, so thank you so much, and it's a very important topic. I can't talk like Dr. Fauci, but I'll try my best. So if your transplant is coming soon, I don't think there is any point of doing immunization now, because all the immune protection will be gone with a transplant and replaced with the donor's immune system. I might, sort of suggest, the donor get immunized so that the immune cells can be transferred to you. Again, although there is no such data exist, we are actively studying that. That's the hope, how the immune transfer happens here. But right, if the transplant is like a year away, and you don't really have a donor identified and takes months to find a donor, then I think you should get the immunization now, at least to be protected until transplant. Post-transplant, again, there is no data as to how well the transplant recipients respond to the vaccine and how well they are protected. The basic principle is, anything would be better than nothing. And, everyone is encouraged to receive the vaccine after transplant. But we also know from other vaccines, flus and others, that the patient's body wouldn't respond. We know if it's given too soon after transplant. So the guideline here, this point, is recommending immunizations after 3 months from transplant at least. We don't know the optimal timing, could be 6 months. You don't want to wait for a whole year. So maybe somewhere between 3 months, 6 months, probably most transplant physicians, hematologists would be suggesting, I think.
Thank you so much, Doctor. In the vein of vaccinations post-transplant, we have a question from someone who's inquiring as to if a donor's immunity is transferred to the patient, why do we have to revaccinate post-transplant?
Yeah, we do not know again. So it happens in other diseases, right? Like if you check measles or mumpus, some patients actually do transfer the antibodies from the donor, but not everybody. It's quite random. And again, I think given the, the side effects from the vaccine is quite minimum. And to my know, in my patients, my practice, I haven't seen any, disastrous side effects from the vaccine. So again, I think it's recommended to boost. And for somebody whose donor was vaccinated, you may have a even better boost with receiving after transplant. Again, it's one of the research projects that are ongoing nationwide.
Thank you so much, Doctor. Our next question is about transplant concerns at various ages. As you noted in your initial presentation, certain diseases present at different ages. So for example, aplastic anemia tends to present in a younger patient, whereas MDS tends to present in elders. When you are considering transplant and post-transplant complications, could you break it down by kind of age range, the things that you think about a little bit, just from the patient perspective? What should they think about and know about that they should consider as a 20-something, a 40-something, a 60-something?
Yeah, so that's another great question. And I would say, it's a little bit disease specific. So for example, for MDS, for example, it's extremely rare to happen for patients who are below age of 20. And so there isn't really much kind of, comparison between, cutoff of age 20 versus the older, right? Whereas aplastic anemia, that's kind of the age group we look at. So, my practice of adult hematology, typically age between 40, 50, the kind of groups that I start to think about ATG first versus transplant first. The transplant data are lacking in all, older adults with aplastic, as I mentioned. 60 above tends to do worse. Within, still decent actually compared to like leukemias, MDS, but worse than the younger aplastic anemia. So over 60 years old, for sure, I would go with ATG. Upfront, between 40 to 50 or 40 to 60. I mean, that's where I think the some of the outcome data start to look a little worse than the younger than 30, 40-year-old, and kind of start to be a gray zone there. I mean, below 40-year-old, I think they universally perform very well in aplastic anemia. For the cases of MDS, it's more kind of granularly looked at on the age 60, 65, 70, as I shown. At this time, I would say that it's very common routine to do transplant in 60s in patients with 60s. When it comes to 70 above, we will be probably more careful, and I think scrutinizing their health conditions, so forth.
We have a question from a patient who wants to know if there is a particular diet or supplements that they should consider prior to transplant in order to improve the potential outcome.
Right. Yeah. So, the short answer is really we don't know, and that there is no known specific diets or supplements that would change the outcome of transplant. It's kind of generic and boring, but I say that continue healthy and balanced diet. If you can, you can gain a little bit of weight coming to transplant, because they often lose appetite and the weight. The one related research is so-called microbiome, or sort of ecosystem within a gut that we carry a lot of bacteria, and there are studies, including ours, looking at some probiotics to see if that modifies the immune system, immune recovery after transplant.
Thank you so much. You may be the first doctor who's ever recommended gaining weight prior to treatment.
Yeah, I mean, we are very humane group of doctors that we allow, pizzas and ice creams and whatever you can eat.
Well, that actually leads to our next question, Doctor, which is that how should a patient go about selecting a center to have their transplant? Often there are geographical considerations, but what would you say are the critical factors for selecting a center for their transplant in order to maximize success?
Okay, it's a good question, and again, I don't want to be self-promoting, but you can always come to City of Hope. But besides that, I think a geographic location is important in terms of the supportive care follow-up. Family availabilities. I mean, it's a huge factor of successful transplant, and be proximate, and you don't have to go to a famous doctor or famous center. You need a good doctor and good center. For when it comes to the rare diseases, maybe aplastic anemia may be included, or MDS in very older populations. Certain rare situations, I think, are larger centers probably maybe a little more favorable in general than smaller centers, which may or may not see the wide varieties in a routine basis. The transplant is a very also kind of center specific or practice specific, and there are lots of sort of minor care items that optimized by the specific practice and the practice setup. So I do advise that you go with the regimen or protocol that each center has and is very familiar with, and comfortable with, essentially. Also, I think communication between your hematologist and the transplant is also important. Some groups like us actually have a combined hematology and transplant, and your doctor takes you through the regular treatments and the transplant treatment. Some centers have a separate departments, but make sure that communications are smooth and transition is smooth.
Thank you so much, Dr. Nakamura. That concludes all of the questions that we have today for this session. And I will say that if you are looking for someone to consult to get a second opinion, or even to look up Dr. Nakamura, you can find it on the AAMDSIF website at aamds.org. And if you click on patients and find a specialist, we have a handy map, so you can find a specialist like Dr. Nakamura, who specializes in bone marrow failure diseases. As we wrap up today, I want to thank you again for your time and attention, in particular to Dr. Nakamura for his wonderful presentation. As a reminder, we are going into our virtual support groups starting at 4 p.m. Eastern, 1 p.m. Pacific. So that's in just a few minutes, about 17 minutes to be precise. The link to that can be found on the homepage of your attendee hub if you click under your sessions. It's the very last one. We'll open the doors a little bit before 4 or a few minutes to the hour. In the meantime, we want to invite you to go check out all the exhibitors and say hi to our friends in the exhibit hall. You can find our March for Marrow booth, where you can click out and sign up for the March for Marrow for the virtual walk-in 5K, which kicks off in a couple weeks. And Dr. Paquette would want me to remind you that you can join his team. And I want to say thank you to all of you today for your time and attention and for all of your great questions. We really are grateful to all of you. So thank you so very much. Everyone have a great day, and we'll see you in support group in just a little bit. Thanks again, and thanks, Dr. Nakamura.
Thank you so much, Julie, and everyone. Thank you.